Diabetes is another one. And here in Pickaway County, we actually lead the state in the amount of diabetics and smokers that we have. Yeah, it's pretty interesting. You know, other risk factors are things like high blood pressure or hypertension, high cholesterol, family history, which we can't really do anything about.
Sure.
And also age. And so we know that as you get older, your chances of having heart disease increase. In fact, of the 80 million people that are estimated to have heart disease, about half of them are 60 or older.
Yeah. You didn't mention obesity.
You're right.
Obesity seems to be at the forefront of most every guest I have on here. That is a growing problem.
It absolutely is, and forgive me, I didn't mean to be remiss about mentioning obesity, but it absolutely is. In fact, every single patient that comes to my office, I always talk to them about dietary changes and exercise, and everyone can increase the amount of exercise they do and to eat healthier too. But you're absolutely right, that is actually a huge problem in the United States. It's a growing epidemic here. They've actually done studies with the CDC, the Center for Disease Control and Prevention, where they map the percentage of obesity across the country. And in the past 20 years, or in the past 10 years, a growing number of our population, in fact, the majority of our population is obese now. And that certainly contributes to heart and vascular disease.
Yeah, I'm not fat, I'm fluffy. But how does that fit in with the obesity bit here in Pickaway County? Do you have figures on that? I mean, are we a fat
unfortunately, I think we are. You know, I actually saw the statistics for Pickaway County, and you know, diabetes, tobacco is up there, obesity is also up there too. High blood pressure and hyperlipidemia or high cholesterol is also a problem here as well too. But you know, it's a problem everywhere, and those are areas that I think we all can work on. And one of the things that I like to do in my practice is to focus on prevention. So exactly the stuff that you're talking about. You know, we do a lot of procedures for people that have disease, and we can help fix them. But for me, the more important thing is preventing the recurrence of that disease, or maybe even preventing the first heart attack to occur in the first place. And I spend a lot of time talking to patients about healthy eating habits, exercise, the importance of taking their medicines, understanding their disease processes, knowing what their lipid panel is. In fact, I tell patients that they should know their cholesterol levels or their hemoglobin A1C, which is a measure of their diabetes control, as well as they know their own social security numbers. In fact, I even tell them too that they should actually have a list of their medicines that they keep in their wallet, so they always know and it's always updated. And so if anything should ever happen to them, and God forbid anything would, but that their providers or their healthcare professionals would have a good idea of what medicines they're on and even what allergies they might have.
Right. Now, you talk about heart disease as such, and it seems as strange to be lumped in with diseases. But this is something that can be totally beat, correct?
Heart disease?
Yeah.
Well, you know,
or once you have it, are you going to suffer, or you're going to be on medicines the rest of your life?
Yeah, for the most part, you're going to be on medicines for the rest of your life. And with heart disease, it's kind of interesting. The concept that's been evolving for the past 10 years is that heart disease also includes a lot of vascular disease as well. So the same processes that could clog up arteries in your heart can also clog up arteries in your legs and also up to your brain to cause a stroke. And so when we think of heart and vascular diseases, we think of everything. In fact, part of my specialty training was also in vascular diseases as well, where in addition to focusing on the heart and all the sub-areas within cardiac disease, including congestive heart failure, valvular heart disease, maybe even some congenital heart disease, and also electrophysiology diseases of heart rhythms. We're also taking a look at diseases of the legs, and also how that also relates to diseases up to the arteries into your brain too. And so when people have known disease, we actually consider them to have the disease for the rest of their lives, but that just means that we have to be much more aggressive in how we treat them for that. And in most cases, they're on medicines for the rest of their lives.
Okay, okay.
Yeah. Which isn't necessarily a bad thing.
Because and you're able to control that.
Yeah, absolutely. In fact, the data that's been coming out shows very clearly that medicines save lives. I know it's a little tough for the patients to take medicines every day, but it's been proven time and time again that some of these medicines actually can prolong your life. And that's what we're in the business of doing, is making sure, or trying to help people live as good, as long, and as healthy of a life as possible. Some of the procedures that we do, so for instance with the heart catheterizations, in certain cases it can help extend your life. So if you're having a big heart attack, we can get in there and open up the artery. Unfortunately, we can't do that here at Berger. For that, patients would have to go up to Columbus. But the heart catheterizations, what they can do is they can help mitigate symptoms. So if they're having chest pain with exertion, if they're having shortness of breath, dizziness or lightheadedness, those are some of the things that we can help fix and perhaps prevent those symptoms from recurring.
Yeah. So do I understand right? Your procedures here at Berger are mostly preventative and diagnostic.
Diagnostic.
So if they need a stent implanted or whatever, they are going to go to Columbus. Yes.
Right. Yeah. So with the services that I provide here, it's basically a full service thing, except for the complex interventions. And interventions are if patients need to open up an artery with balloons or stents, or even for the electrophysiology portion of it, so the heart rhythms, the electrical conduction of the heart. We can now do very complex procedures, but can actually perhaps even cure people of things like atrial fibrillation or atrial flutter, or maybe even irregular heartbeats that causes their heart to beat fast and irregularly. We can actually make those diagnoses here now, but to do the curative therapies, patients would still have to go up to Columbus.
Okay.
But the one thing that I'm kind of excited about here is that as far as the diagnostic capabilities and the tools that we have in our tool bag, we're increasing that here at Berger as well. So Berger's always had a very good diagnostic department. For instance, they do stress tests, they do a nuclear stress test, and now in the past 2 months we've added to that. A stress test is a test that we do to help identify what risk a certain person has for heart disease. And so say if Mr. Smith came in with chest pain, what we do is I'd take a good history for him, identify the risk factors, and we can get a good idea if he has a low, intermediate, or high risk of heart disease. And then depending on that, then we can further stratify the risk by further testing. And one thing is a stress test. And what a stress test is really 2 components to it. The first is how we stress the heart. So we can either have someone run on a treadmill, or we can give them drugs to either help the heart pump harder and faster, or to open up the blood vessels to increase perfusion of blood flow to the muscles. So that's the first part. And the second part is how we image the heart, or how we look at it. And we can either do that through nuclear tests, which is a radioactive tracer that we infuse in, and then we see how it distributes in the heart muscle itself, or we can image it with an echo. And here at Berger, historically, we've done mostly the nuclear tests. But in the past couple of months, we are now offering a stress echocardiogram as well, too. And then pretty soon, we'll be offering even another type of way to stress the heart. And so whereas before we had maybe one way of doing a stress test, pretty soon we'll have 5 ways of doing it. And the reason why that's actually kind of important is because depending on the person, depending on their risk factors, depending on their medical conditions, depending on what medicines they're currently taking, we can more tailor or better tailor which tests we do to help us better identify what their risk is going to be.
Yeah. Then does risk fit in for gender, nationality, race?
Yeah, that's another great question. That's a topic that we could spend another half hour talking about altogether. But the gender question is really interesting. There's a growing debate amongst the cardiologists and in the cardiology community as to what exactly is heart disease in women and how does it present. Historically, people always said that chest pain in women or heart disease in women isn't like heart disease in men. So they might not typically get the chest pain in the middle of their chest that radiates to their left arm or to their jaw, associated with shortness of breath, sweating, dizziness, and lightheadedness. And I think what that pointed out to us is that we have to be just a lot more cognizant of the gender differences in women versus men. And so, for instance, a good example of this is before we would do stress tests in women, we'd have to, again, be a little more selective about what kind of stress tests to choose in women. If that were positive, we'd do a heart catheterization. And a lot of times, you would see that they don't have significant disease. And we know that for women, because of their hormones and the estrogen, they're a little more protected than men are before menopause. After menopause, the risk is about the same as men. Mm-hmm. But for women that are premenopausal, their risk is going to be a little bit lower. And if we did a heart cath and showed that their arteries, their big arteries, were relatively free of disease, we'd give them a hearty handshake and say, you're fine, this was probably something else. Mm-hmm. What we now know, though, is that perhaps that's not necessarily true. And there's a whole growing concept of macrovascular or microvascular disease. And a good way of thinking about it, the way that I like to think about it is